Welcome to the second year Clinical Skills Cardiovascular Examination Review video. Besides going over the normal examination procedure, this video includes recordings of heart sounds and murmurs to help you get acquainted with some common abnormalities. For these sounds to be reproduced adequately, the volume setting on your computer must be adjusted towards maximum. If my voice sounds too soft now, you should adjust the volume setting on your computer so that it's readily audible. Determining the nature, differential diagnosis, and severity of cardiovascular disease begins with an interview of the client or owner. Commonly reported clinical signs of heart disease include exercise intolerance, transient weakness or collapse that may include loss of consciousness, which is known as syncope, dyspnea or difficulty breathing, cough, weight loss, or a familial history of heart disease. Young animals with severe disease may be stunted or smaller than their littermates and less inclined to engage in physical activity. You need to investigate the circumstances surrounding clinical signs as well. Dogs that cough from heart failure often do so at night or after an extended period of recumbency. The cough of heart failure is a husky, productive cough that may end with a period of gagging, possibly producing blood-tinged foam. A harsh or honking cough may still result from heart disease if the heart is large enough to put pressure on the intrathoracic airways. Weakness or collapse from heart disease may evoke historical information that resembles problems in other systems, such as the respiratory, nervous, or musculoskeletal systems. Syncopal episodes are notoriously difficult to distinguish from seizures, and the critical differentiating information often comes from the history. It's always appropriate to determine historical data relating to dietary, husbandry, and preventive care. Examination of the cardiovascular system begins, like other examinations, with some basic visual observations, including the rate, depth, and effort of respiration. Animals having significant dyspnea from heart disease may actually be hypoxemic and stressed to the point they are unable to undergo a physical examination. Like most examinations, it's important to be consistent and thorough for the cardiovascular exam. Starting at the front end of the patient, check the mucous membranes of the lips and gums for color and perfusion. The normal color is pink, ranging to rose. Dark to bluish membranes, that is cyanosis, is an indication of substantial hypoxemia with greater than 5 grams per dl of deoxyhemoglobin present. Whitish or pale membranes may indicate anemia or possibly poor perfusion of the membranes, which can occur with severe heart disease. Inflammation or hyperperfusion both can appear as a deeper red color than normal. This is not necessarily a good thing and sometimes suggests septic shock. Test capillary perfusion by pressing gently and briefly on the membranes of the gums to blanch out the color. Color should return within 2 seconds, and diminished perfusion is suggested if it does not. Differential cyanosis is present if some regions of the body are cyanotic while others are not. The classic condition resulting in this finding is the reverse or right-to-left shunting ductus arteriosus, where membranes of the prepuce or vulva are cyanotic, but the oral membranes are not. Obstruction of arterial blood flow to a limb also causes differential cyanosis. This can be best observed at the nail beds, and comparison between the legs can be extremely valuable. Always examine the jugular veins for inappropriate distension or pulsation. This should be done with the animal in a normal standing position and usually does not require shaving over the jugular. You must be able to elicit the jugular vein for the cardiovascular exam. To do this, you should not hyperextend the neck to the point that the muzzle points at the sky. This stretches the skin too much and may cause difficulty in viewing the vein. Grasping the muzzle, point it about 45 degrees to the side and about 45 degrees up. At the same time, push the head caudally. Make sure that you can see the jugular vein first by holding it off at the thoracic inlet with your thumb or finger. After holding off the vein for a few seconds, release to allow the blood to drain quickly, which it should. It is often easiest to identify the jugular vein by seeing it collapse quickly. Now that you know where it is, you can make an adequate assessment as to whether it distends normally or not. The normal jugular vein can often be seen to pulsate slightly at the thoracic inlet in rhythm with the cardiac cycle, distending during systole with tricuspid valve closure, and also with respiration, distending slightly with inspiration. Releasing the jugular vein after holding it off at the thoracic inlet allows it to drain quickly, usually in less than a half a second. A delay in drainage suggests that the right heart is unable to accommodate this small bolus of blood. Similarly, distension of the jugular vein above the thoracic inlet suggests any of numerous conditions resulting in right heart incompliance or right-sided congestion, that is, heart failure. Very careful observation of vein pulsation may allow you to further define the nature of the problem. The jugular vein distends during ventricular systole with tricuspid regurgitation, causing a V wave, but distends with atrial systole, that is an A wave, if there's an incompliant right ventricle, or the atrium contracts when the tricuspid valve is closed. That one's called a Cannon A wave. Make sure the jugular veins are symmetrical. If thrombosis is present, it's sometimes possible to palpate the jugular as a firm clot-filled cord. Continue examination of the jugular veins by testing for an abdominojugular or hepatojugular reflex. This is done with the animal still in standing position while holding the head for jugular observation as before. The cranial abdomen is compressed in an upward and forward direction, which has the effect of briefly diminishing venous compliance, thereby increasing venous return. The compliant right heart normally accepts this instant transfusion by distending readily with minimal increase in pressure. Jugular distension may be slight and is very transient. Distension of the jugulars for more than a moment or above the level of the thoracic inlet is abnormal and suggests the right heart disease as before. Now here's an example of a dog with jugular vein distension, in this case secondary to pericardial effusion and tamponade. If you watch very closely, you'll see the jugular vein distend with inspiration. While this can be seen in normal animals at the thoracic inlet, distension or pulsation above this level is abnormal and suggests fluid overload, tricuspid regurgitation, or a range of diagnoses that result in impairment of right ventricular filling or right heart failure. Here now is an example of jugular pulsation in a cat that had severe cardiovascular disease. It so happens that a small component of the arterial system can be observed directly by examining the ocular fundus. I must admit that I do not include this as a routine component of my cardiovascular examination. The photos show a normal canine fundus on the left and one with hemorrhages due to systemic hypertension on the right. Unfortunately, animals with severe systemic hypertension may have an initial presentation of sudden blindness with detached retinas and ocular hemorrhage. Sometimes this can be observed from across the room since pupils of the affected eyes are dilated and afford a substantial view of the posterior globe. We're going to check this cat now for a thyroid nodule. Feline hyperthyroidism is primarily an old age disease, but has been seen in cats as young as 4 years. I prefer to use my index and middle fingers for this, but many use the thumb and index finger. The idea is to make a dam with your fingers so that the thyroid gland cannot slip between your fingers but must pass under them. Start at the larynx and move your fingers slowly and steadily all the way to the thoracic inlet. You're trying to sense the thyroid gland blip under your fingers. This cat has a large enough thyroid that you may actually see the blip on the video, but that isn't how the sign is elicited. It's done by touch. With the animal standing, palpate the thorax with your fingers to determine the location, extent, and character of the cardiac impulse. Of course, this will be influenced by the animal's conformation and body condition. You're going to feel the apex beat much better in a skinny, deep-chested thorax. With cardiac enlargement, the apex beat of the heart tends to shift caudally, so that you may obtain some impression of cardiac enlargement this way. At a very basic level, consider that the apex beat of a dead animal is very weak, like non-existent. A patient that is in shock will have a weakened, rapid apex beat. A very active and athletic animal, or one that is excited or nervous, will have a strong impulse. So this is a very crude index of heart function, but one that should not be ignored. Experienced clinicians may be able to obtain an impression of cardiac hypertrophy with their hands. The hypertrophied heart may cause a heave or a lifting sensation, called a lift, where it contacts the thorax. The normal apex beat is also more prominent on the left than the right. Obvious displacement of the impulse may suggest physical displacement of the heart within the thorax due to a space-occupying mass, or the collapse of a lung that would normally keep the heart away from that part of the thoracic wall. You should also palpate the thorax in an attempt to elicit a thrill caused by blood flow turbulence. By definition, a thrill is present in heart murmurs of intensity 5 or 6 out of 6, as evidenced by a buzzing or vibrating sensation that's best elicited using the flat of your hand, pressed as lightly as possible against the thorax. This sensation also is difficult to describe, but you can simulate it using a latex glove or balloon that is being filled rapidly at the faucet so that the flow into it is turbulent. Don't mistake the apex beat for a thrill. If it isn't the same sensation at all. For the cardiovascular exam, you will palpate the abdomen as for any complete physical examination. Pay particular notice, however, to cranial abdominal organomegaly due to hepatic or splenic enlargement, or both. Each of these may suggest right-sided congestion. Check specifically for abdominal effusion. This may be obvious if there's a great deal of it, but you may need to blot the abdomen to best observe it. Keeping one hand on the side of the abdomen, tap the opposite side gently but briskly with your other hand. You're attempting to sense a fluid wave with the hand that rests on the abdomen. This is a difficult sensation to describe, but you can probably imagine it, and you can simulate it using a fully filled hot water bottle. In small animals, you will palpate both femoral pulses at a minimum, and possibly other pulse locations as well. Beginners are sometimes surprised at how proximally they must palpate in the groin to find the pulse, by gently trapping the femoral artery against the femur. As a second-year student, you are expected to find the femoral pulse and be able to report the pulse rate without fail. You will be tested on this. You will also evaluate the pulse rhythm and character and correlate this with the cardiac cycle. It may surprise you that your fingers are virtually insensitive to the actual arterial blood pressure, but are sensitive to the pulse pressure, that is, the variation between systolic and diastolic pressure. In essence, the pulse character depends on the cardiac rate and stroke volume and the state of the vasculature, whether vasodilated or constricted, and how compliant. Diminishing stroke volume and increasing heart rate results in decreasing pulse pressure in the sensation of a weakened pulse. Hyperdynamic pulses result when there is increased stroke volume due to excitement or sympathetic stimulation, but can also result when there is a rapid diastolic runoff of blood to the periphery, as may occur with vasodilation. Bounding pulses are the extreme in this spectrum and result from conditions such as patent ductus arteriosus or marked aortic insufficiency, where there is a rather large escape hatch for the blood to exit the arterial vessels. When ausculting the thorax, be sure to listen to both the heart and lungs. This should be done with the animal standing, unless there is a very good reason not to. Like all physical examinations, you'll need to make an effort to avoid causing artifacts that you can misinterpret. The ideal patient stands quietly, doesn't pant or move, holds its breath while you listen to the heart, and breathes deeply and evenly when you listen to the lungs. I have yet to meet this ideal patient, and so one learns to mentally filter out extraneous noises, much as you do when trying to hold a conversation with an individual at a noisy party. It helps to have an assistant hold the muzzle of a panting dog gently and intermittently so that you can hear the heart for brief intervals. Clamping down on the muzzle for an extended period often makes them struggle and compounds your problem. In my years of teaching auscultation to students, I've encountered very few who could not hear the appropriate abnormalities if I placed the stethoscope for them. The two issues for beginners are to first, recognize sounds that are abnormal and normal, and second, move the stethoscope around the chest to find them. As you train your ears, you'll need less time at each stethoscope position to determine whether the sounds are normal or not, and you will move quickly around the thorax to explore the field in search of abnormalities. One of the greatest auscultation challenges is the purring cat. There are several methods you can use to get them to stop for a moment. All usually involve some method of ticking off the patient a little bit. Some advocate an alcohol-soaked cotton ball near the nose or some lateral pressure on the larynx. I prefer to place the cat near the faucet with the water turned on just enough to distract the cat into wondering if I would dare to get them wet. In the dog, sounds and murmurs emanating from specific valves tend to radiate to a corresponding location on the thorax. The usual mnemonic for remembering these locations is that the valve areas spell PAM in a cranial to caudal direction, where P stands for the pulmonic valve position at the heart base, near the third intercostal space. A stands for the aortic valve position at the fourth intercostal space, also near the base, and M stands for the mitral position at the fifth intercostal space, but towards the apex of the heart. Nobody counts intercostal spaces to determine these locations, but uses the available landmarks with the animal in standing position. With the stethoscope in the pulmonic position, the headpiece disappears underneath the triceps musculature. The aortic position is just caudal to the pulmonic position, such that the headpiece of the stethoscope is now visible. Some textbooks depict this position as being slightly dorsal to the pulmonic one. I can't say that I'm able to discern this distinction myself. The more normal mitral valve position is one rib space further caudal and also ventral to the aortic position. Keep in mind that these positions are guidelines, not absolutes. When the heart enlarges, for example, the mitral valve position shifts caudally with the rest of the heart. With extreme left atrial enlargement, the mitral murmur may actually project over the back, since that's the direction that the regurgitant jet is directed. Cats often don't describe to these guidelines at all, so that mitral and or aortic murmurs may be most audible simply near the sternum. When you're first starting to auscult, it would be a good idea to make sure you can pick out the big features before you work on the nuances. The big picture for murmurs is, first, is the murmur systolic, diastolic, or both? Second, is it more intense on the left side of the thorax or the right? Third, is it more intense towards the apex of the heart or the base? Now we're going to listen to some heart sounds. In each case, the heart sounds will be played first, along with a photograph to indicate the position on the thorax where the recording was made. Then I'll give you a brief narration of what you might hope to hear. Then the recording will be played again. This dog has a split S1 sound due to slightly asynchronous closure of the atrioventricular valves. I consider this to be a normal finding in the dog, but it's often easier to hear with slower heart rates. Therefore, it's completely normal to hear this in large animals, but unlikely to be normal in a cat. Pathological causes of a split S1 derive from asynchronous activation of the two ventricles, which might occur with a bundle branch block, or beats that originate in the ventricles, such as premature ventricular complexes or ventricular escape beats. Instead of the normal lup-dup, 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 we hear in this dog drup-dup, 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 drup-dup. So there's a very slight split of the first heart sound. Here it is again. This is a clear example of a systolic click, an extra heart sound that's occurring smack dab in the middle of systole. This sound is commonly mistaken for a gallop sound, and the distinction is very important. This systolic click occurred in a middle-aged dog with early mitral valve disease, so early that there wasn't even a murmur yet. It's thought to occur with mitral valve prolapse in mid-systole, much like the sail of a sailboat that snaps when it fills with wind. By definition, a gallop sound is an extra diastolic sound and usually implies a significant problem in small animals. To determine the timing of the extra sound, it may aid you to call out the S1 and S2 sounds to yourself, then attempt to determine the timing of the extra sound like this. Lup-dup, lup-dup, lup-dup. 1 2 1 2 1 2 1 2 1 2 1-2 1-2 1-2 1-2 1-2 1-2. Determining that the extra sound is between the S1 and S2 means that it's during systole. Here's the sound again. That was an S3 gallop sound in a cat that had restrictive cardiomyopathy. Hopefully you can hear the triple rhythm from which the name derives. I'm sure that this was an S3 gallop based on the type of heart disease the cat had, but I couldn't distinguish between an S3 and an S4 at this heart rate except by using a phonocardiograph machine. A gallop sound is an extra diastolic sound by definition. They generally have a low-pitched thudding quality to them that is very unlike the systolic click you heard before. An S3 gallop sound occurs immediately after S2, like this: 1 2 1 2 1 2 thud, 1 2 thud, 1 2 thud, 1 2 thud. An S4 occurs immediately before S1. The 1 2, the 1 2, the 1 2, the lup-dup, the lup-dup, the lup-dup. Gallop sounds are difficult to record because of the low frequencies of the sounds involved. Here it is again. In mitral valve regurgitation, the heart ejects more blood volume than normal and is hyperdynamic. If the dog is not obese, you'll feel an increased apex beat impulse on the left side of the thorax that coincides with the loud slamming S1 sound that you hear with this dog. The holosystolic murmur begins at the same moment as the S1 sound, and the intensity is constant, more or less, over the course of the murmur. Characteristically, a holosystolic murmur extends past the S2 sound. I can't hear the S2 in this recording, and so I can't tell you that this was the case. This particular murmur has a slightly musical component to it, by which we mean that there are some higher frequencies audible. It's extremely important that you learn to recognize the heart rate and cadence of a well-compensated cardiovascular system in the dog. This dog's heart rate is about 80 to 85. Unless being given drugs that artificially lower the heart rate, I would conclude that sympathetic stimulation is low and that it's unlikely that left heart failure is impending. Here's the murmur again. This dog had a patent ductus arteriosus, or PDA. The important feature of the murmur is to recognize that it is continuous, that is, the murmur never stops. It's clearly accentuated, that is, louder during systole, but the murmur is sustained throughout diastole as well. Here's my imitation of a continuous murmur with a systolic accentuation. Shh, 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 shh. And here's systole only for comparison. Shh, 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 shh. The PDA murmur is sometimes described as a machinery murmur, which is understandable, but it's the continuous nature of it that your ear needs to pick up. Also notice the location of the murmur is over the pulmonic valve area. The turbulent blood flow occurs right in the proximal pulmonary artery at the same location as turbulence from a pulmonic stenosis. You may well live long enough to misdiagnose a PDA by not listening far enough cranial on the left thorax. Here's that murmur again. This dog has an ejection type murmur that resulted from subaortic stenosis. Note the location of the stethoscope headpiece at the aortic valve area. The attributes of an ejection murmur are that it starts after the S1 sound and stops right at the S2 sound. I can't hear either the S1 or S2 in this recording, so I can't tell you whether the murmur fulfills those criteria. Another characteristic of the ejection murmur is that it has a crescendo-decrescendo quality for its intensity. It gets louder during the first half of the murmur and gets softer during the second half. The recording illustrates this characteristic pretty well. Listen again. That was another systolic crescendo-decrescendo or ejection type murmur, this time from a dog with pulmonic stenosis. The only real difference between this murmur and the last one is the location, this murmur being a little farther cranial over the pulmonic area. You can imagine how it might be possible for you to get these two confused if you weren't able to localize the murmur very well. Sometimes it's easier to do that just by feeling for the thrill with the flat of your hand as we looked at before. This murmur was due to tricuspid regurgitation in a dog with substantial tricuspid dysplasia and a little bit of pulmonary hypertension. It's important to realize that the pulmonary circulation is a low pressure system compared with the left. A similar amount of tricuspid regurgitation results in a softer murmur than corresponding mitral regurgitation. It's not uncommon for a dog with tricuspid dysplasia to reach maturity or even old age before a murmur is detected, because the murmur may be very, very soft. On the other hand, an intense tricuspid murmur is very often an indication of pulmonary hypertension. This dog's tricuspid murmur was crescendo and decrescendo in quality, much like an ejection murmur, even though a tricuspid murmur isn't supposed to sound that way. Here's a diastolic decrescendo murmur in a horse with aortic insufficiency. This murmur is readily audible because of the frequencies of sound involved. The loudness of the murmur does not imply the severity of disease in this case. The murmur is generated by fluttering of the aortic valve as blood regurgitates back over the valve's surface. It's sort of like a kazoo. In this example, the murmur starts right after the S2 sound and there's a long decrescendo before the next beat. The horse has an arrhythmia as well. Did you hear it? Every fourth P wave was not conducted, so that there is a pause equal to about 2 cardiac cycles every time there's an AV block. Second degree AV block is often a normal in the horse and simply indicates resting vagal tone. Here's the murmur again.